It became very clear to us in the early days of Seva, almost 50 years ago now, that without some measure of healthcare, even basic healthcare, women and their families could never emerge out of poverty and move towards their goal of economic empowerment and self-reliance. We see healthcare and the struggle against poverty and the struggle for economic empowerment deeply intertwined. One without the other makes no sense. That putting technology in the hands of frontline workers will be critical in the slow march towards universal healthcare. What we did also learn from the Swasthlet experience are a couple of things. One is that all the technology systems, the device themselves and the procedures should be developed right in the beginning in consultation with informal workers. Okay. Because oftentimes we develop things in the lab, which is fine. Nothing wrong with that. We all do that. But they may not suit the realities of different groups of people in our country. So at least early in the process, there should be a consultative process. That's what we found. Whether it's for developing insurance products, health products, medical diagnostic tools, and whatsoever. There is very little preventive focus in primary healthcare. Even today, it's more curative, and there is a curative need, there is no denying. There is a strong need for early detection and screening. And I think, at the grassroots level, at the last mile, at the doorstep, and I think that's where medical technology that can be put in the hands of frontline workers at the last mile becomes critical. Because early detection, screening, and I think, this can be planned, as I've said in my bullet point there, it can be planned in a decentralized manner, where those of us who are developing the medical technology sit together with local people and actually plan together. It's exciting. Marrying everybody's talents, pooling everybody's talents, and that can be done. And they are the best to tell us what works for them. Because, one size doesn't fit all. Decentralized planning by local people, decentralized implementation, doorstep approach through frontline workers that I've written here, those are guiding principles. But in this large country of ours, it necessarily has to be a tailor-made approach. Yeah, absolutely. Because, for example, I'm thinking even in the state of Gujarat, the northern part of Gujarat and the western part, which is Kutch and more desertified, we'll have to think creatively. There's scattered hamlets, scattered populations. One has to think both in terms of tailor-made, plus also, whether the revenue model would work for such far-flung communities and scattered communities. Then in South Gujarat, we have forested areas and some very inaccessible areas where, also internet connectivity is a huge issue still, so on and so forth. So there are these practical issues which only local people can guide us. And we can, of course, come up with alternatives, but it's the local people who will always tell us what will work and will not work. And we've always been in favor, as you can see in the slide, of putting such technology, such as you are developing, such as we have tried out in the past, in the hands of women.
Everyone, this is Vandana from ZDeo. Very warm welcome to all of you, and thank you for joining us today for the MedTech Connect Diagnostics 4.0 webinar series on diagnostics at the last mile. We are delighted that you could join us for the second episode of a series in our monthly interactions where we invite leading experts in the MedTech domain from India and the world to share their wisdom and insights. Before we start, some quick housekeeping rules. Please post your questions and comments on the Q&A section as you have them during the webinar, and we'll try to take them up at the end of the webinar with Dr. Miraiben. The attendees are on auto mute throughout the webinar to avoid any disturbances.
Hello everybody, this is Manish from the Healthcare IT Experts blog. I would also like to welcome my co-hosts and co-moderators, Mr. Pawan Sanuti, GM Corporate Strategy from Cyient, who is leading the partnership with Zinteo to evolve the MedTech Connect ecosystem. And you have already heard from Dr. Vandana Sarda, Principal from Zinteo. I would now like to request Mr. Pawan to say a few words about the webinar series, its genesis, and Cyient and Zinteo's India 2022 coalition. Mr. Pawan.
Thank you, Manish. A very warm welcome to all of you. Diagnostics 4.0 is the latest offering and endeavor from MedTech Connect in an effort to strengthen the medical technologies ecosystem in India. Many of you have participated in the MedTech Connect All-Partner Workshop in July at the Cyient office in Hyderabad. We had a truly diverse crowd with approximately 40 partners from organizations across the value chain present in the room to ideate, collaborate, and create solutions to very specific problem statements. We worked through structured and interactive sections to identify specific areas in which we can drive impact. We also left the room agreeing that it was important for the ecosystem to continuously meet, and this webinar series is an attempt to do just that. These webinars will be held monthly, and we are proud to present episode 2 of season 1, Diagnostics at the Last Mile, with Dr. Miraiben Chatterjee of Seva. If you haven't already, we urge you to also please watch episode 1 with Dr. Sriram of Tata Trust, which is posted on our website, www.medtechconnect.in. For the new partners joining us today, MedTech Connect is a collaborative healthcare ecosystem platform led by Cyient and Zinteo, the India 2022 coalition. Our vision is to accelerate the journey of medical technologies from lab to market and help improve affordability, availability, and accessibility of these solutions to the last mile. Founded in 1991, Cyient provides engineering and technology solutions to global industry leaders. We deliver innovative solutions that add value to businesses through the deployment of robust processes and state-of-the-art technology. We work across multiple industries from aerospace to communications, transportation, and energy. We've also been active in the medical technology space for the past 10 years, our fastest growing industries. We are a partner in the Zinteo India 2022 coalition and lead the Healthcare Impact Track. Zinteo is a platform for galvanizing leaders and catalyzing ideas and fusing them into new projects for new growth. India 2022 is a business-led coalition committed to leveraging the power of collaboration to unlock future-fit growth opportunities in India, aligned with the Government of India's development goals. In healthcare, we are looking to make affordable diagnostics accessible to as many people as possible.
Thank you, Pawan, for your remarks. Today we are glad to have with us and learn from the members of the MedTech Connect family to share their experience on diagnostics in public health. Ladies and gentlemen, I request Dr. Vandana to please welcome and introduce our esteemed speaker to our audience. Dr. Vandana.
Thank you, Manish, and a very warm welcome to you, Dr. Miraiben. Is it okay if I revert back to Miraiben, as it looks
Of course,
more...
Mirai is also fine. Quite informal. Thanks, Vandana.
Thank you. For the records, Miraiben, I'm a huge fan and very inspired and awed by what you do. So what say everyone who's attending? More power to her and all the Seva sisters because of her relentless efforts. Really so very well. Glad that you could join us, Miraiben. And it is my absolute honor and privilege to formally introduce you today to all of the audience. Miraiben is the director of the Social Security team at Self-Employed Women's Association, popularly known as SEWA. She is responsible for SEWA's healthcare, childcare, and insurance programs. Miraiben is currently chairperson of the National Insurance Bimo Seva Cooperative Limited and actively involved with the Lok Swasthya Health Cooperative, of which she is a founder. Both cooperatives are promoted by Seva. In addition, she is chairperson of the Gujarat State Women's Seva Cooperative Federation of 106 primary cooperatives with 3 lakh members. Miraiben joined Seva in 1984 and was its general secretary after its founder, Ela Bhatt. Miraiben also serves on boards of several organizations, including the Public Health Foundation of India, Save the Children, and Pradhan. She was advisor to the National Commission for Enterprises in the Unorganized Sector and is in the advisory group on community action of the National Rural Health Mission. She was also a commissioner in the World Health Organization's Commission on the Social Determinants of Health. Miraiben was a member of the National Advisory Council appointed by the Prime Minister of India in 2010, and she was conferred the Global Achievement Award by the School of Public Health, Johns Hopkins University, USA, from where she has a master's. Before that, Miraiben has done her BA from Harvard University in History and Science. So again, a very warm welcome to you, Miraiben.
Absolutely. And first of all, thank you very much, Dr. Vandana, Dr. Manish, Dr. Pavan, and all the friends who are on the net with me today. It's my pleasure to share experiences and some ideas and exchange views with you and hopefully have some interaction as well through your questions. Delighted to be here.
And as you know, and as Pavan mentioned, this season is about diagnostics at the last mile. And today we would want you to deep dive based on your experience with coming up with various healthcare offerings for the Seva sisters into how diagnostic innovations can be taken to the last mile. So let me start by asking you, would it be fair to say this, that the Seva member network is as last mile as it gets? Basically, we're talking about the informal women workers in the country. And I've heard you say somewhere that informal workers are bearing the cost of inadequate healthcare investment. And the worst hit are these crores of informal women workers. Your views, please.
One of the articles of faith in Seva is how can we put technology in the hands of the poorest of our citizens, especially the women of our country. And as the first slide shows you, the world of work of our sisters is a very different one. But to answer your question before I go to the slide, Vanna, yes, it became very clear to us in the early days of Seva, almost 50 years ago now, that without some measure of healthcare, even basic healthcare, women and their families could never emerge out of poverty and move towards their goal of economic empowerment and self-reliance. So we see healthcare and the struggle against poverty and the struggle for economic empowerment deeply intertwined. One without the other makes no sense. So in all our programs, whatever be our health programs, there is a livelihood and economic component. In fact, we say that health itself is an economic. It's not simply a service. It's an economic necessity, healthcare. It's about survival. And similarly, in all our economic and livelihood activities, be they the salt workers you see in the photograph, or any street vendors or home-based workers, in all our work there has to be, and there always is, a health component. Health education, health awareness, and others, as we'll see in a few minutes in some other slides. The reason I'm starting with this particular slide today is because this is the abiding reality of the mass of workers in our country who are informal. And we are speaking of upwards of 50 crore or 500 million workers. some of whom are below the poverty line, some are hovering at the poverty line, and some above the poverty line. And they are poor, but they are very economically active. As I mentioned, the slide here, the photograph is one of our members, one of my sisters, who's a salt pan worker in the run of Kutch, making inland salt. And it is these small enterprises and the efforts of millions of our fellow citizens who are contributing to India's growth story, as you can see from the slide, contributing at least 50%, if not more, to our GDP, to our national savings, and significantly also to our exports. And the reason it's important to understand the characteristics of informal workers, perhaps we can go to the next slide, is that all our efforts, therefore, for the last mile have to be embedded in this reality. So our world, the world of work of informal workers, particularly women, is unfortunately characterized by no work security nor income security, and therefore little food security. And importantly for us in the public health sector and the health sector, very little social security, little or no social security, social protection, including, of course, as you can see in the slide, insurance, sick leave, maternity leave, childcare. Now, happily, our government has increased the maternity benefits and leave for women workers in India. But I must tell you, it's for hardly 2 to 3% of the workforce. The rest, who are in the informal economy, cannot dream of having any maternity leave or any benefits of any kind. Of course, as you know, many of you would know, being fellow citizens, there are very few laws for informal workers in India. And even those that exist, unfortunately, are largely on paper as far as the informal economy workers are concerned. There's very poor enforcement. And to be fair, it's also very hard to enforce. Because another characteristic of informal workers is that their workplace is very different. Their workplace could be their home. In the case of home-based workers, their home is their workplace. All the markets and bazaars of our city as street vendors, or the fields where there's small farmers like the photograph of tobacco farmers, which you can see in the slide, or pulling loads through the streets of the city like you see the two women there who are what we call Mathoda Kamdar, head load workers. And of course, in the absence of childcare, as you can see in the slide, the little one is also dragged through the dusty streets of our city. Also, I'd like to say that there is an overlap between informality, poverty, and gender, where disproportionate number of informal workers are not only poor, but are women.
So thank you for really giving this elaborate view about the characteristics of the informal workers. What I understand, you and your team members have done a phenomenal job of organizing the healthcare services at Seva for these women workers through the Lok Swasthya Seva Health Cooperative Limited. So request you to tell us a little bit about the status of this health cooperative, its activities, and what are the upcoming initiatives.
Sure. There's one more slide before that, if I may, because I think before we understand about the health cooperative, it's important to understand about the mother organization, Seva. So if we could have the next slide. We'll come straight into the health cooperative as you've requested.
Thank you.
So Seva is a national trade union. It is India's largest union of informal workers with 1.7 million members. Of course, the largest number in the state of Gujarat, because that's where the Seva movement began, founded by Miraiben, and many of you would have heard her name. But now what many of you may not be aware is that we've gone way beyond the borders of Gujarat and have now a presence in 18 states, the next largest presence of almost 600,000 or 6 lakh workers in the state of Madhya Pradesh, one of our poorest states. One of the things that we found all these years is the importance of organizing. If we want to help women on the road to economic empowerment, we have found they cannot do it alone. building their collective strength and bargaining power is powerful, and that's what helps them out of poverty, collective strength. And that comes through these small, medium, and large membership-based organizations, which are democratic workers' organizations, like cooperatives, self-help groups, their federations, and so on. And another characteristic, I think, which is important about Seva is that we're inspired by the values of Gandhiji, so inclusion and local, decentralized. And some of these ideas I'll be also speaking to when we speak about what next and how can we use technology at the last mile. One point I do want to say is that over the years, we've seen deep insight among the women of this country. They may be poor, they may not be very literate, they haven't had the kind of opportunities you and I have, but they have deep insights and experience and know better than anybody what they need and how to reach the last mile. Therefore, we've always had a deep faith in their abilities, their strength, and their commitment, including in the use of technology. So I just thought I'd mention that here. Next, please. Next slide, please. So one of the organizations that Seva has promoted, one of those 5,000, which Vandana has mentioned, is our health cooperative, which is called Lok Swasthya Cooperative. And the reason we formed the Lok Swasthya Cooperative is because women said, thanks to Seva, we now have our own Seva bank. We have greater access to financial services. We have a bank account in our own name. I'm talking about way back in 1974 onwards, way before all the government banking programs, I must say. So they said, yeah, Seva has helped us, save our monies, hard-earned monies. We have greater livelihood opportunities. Through our union, Seva has helped us defend our livelihoods and even get minimum wage. But whatever we earn goes in healthcare costs. And like for the rest of the country, 80% of our members still also go to private care. Although I must say, in states where the public health system is improving, like Gujarat, they're increasingly, and we're encouraging this, using the public health system so that their hard-earned monies are preserved and conserved. So it is because the demand came from the members that, lack of healthcare has severe economic consequences. So first of all, they said, we'd like to know about our bodies. We'd like to know how to stay healthy, the preventive aspect. And that's why from the beginning, our flagship program has In Health, and then continued with the cooperative, healthcare cooperative, has been on health education and awareness. And as you can see on the slide, the focus is on primary healthcare and diseases and conditions that are experienced by women, girls, young children, and their family members. And in the last 10 years, more and more focus on non-communicable diseases, including early diagnosis and screening, which connects with our subject, and I'll speak to this later on. Occupational health, because as a workers' organization, we find that this is a most neglected area. It's as if women don't have any work-related health issues, or they say, oh, what's there if you have a little bit of low back pain? What's the big deal? And also, of course, we speak a lot about nutrition. Of course, poverty restricts your food basket. But within that, there is much that you can do. There are highly nutritious grains like millets and so on, which are not high cost. So a lot of emphasis on health education of young people and our members. A more recent innovation is what we call the Seva Shakti Kendras, which are actually an information and empowerment hub where women can come. It's a physical space. It might be just even a desk in the panchayat office in many rural areas. In urban areas, harder to get space. So some of our members give their angan or one room part-time for this kendra, for this center. And at this center, they get all the information on the public health services and entitlements that are their due, but not just the information. They also get the hand-holding that they need to navigate the systems. Some of you all would have read in the newspapers, there was in the Hindu, I believe, just 2 days ago, a large article by Professor Jean Drez, who had done a study on one of the maternity schemes, And large numbers of women simply did not know. So if you don't know, if there's such information asymmetry, then how can you even demand the services and the entitlements? So step one is knowledge. And as we all know, knowledge is power. So the Seva Shakti Kendras are set up both in urban and rural areas and in Gujarat and in other states. A third activity are our low-cost pharmacies, because our members said, if you recall, whatever we earn, we spend in health expenditure. And when we did a deep dive into that, we found that the major cost was medicines, in fact. Of every 100 rupees spent on healthcare, about 70 was spent on medicines and other equipments. And so at their request, their demand, first in the Seva premises, we started a small pharmacy, buying medicines in bulk from the large companies and the big wholesale pharmacy bazaar here in Ahmedabad. And now we have 4 such pharmacies, 3 of which are running round the clock outside large public hospitals. So this is another service. And this has also, by the way, made our cooperative viable, because we found that even with a very low markup, because obviously we are not in the business of exploiting people and making money off their illness, but even with a small markup to cover costs, significant revenues are generated, and this alone has made our cooperative viable. A word here on the cooperative, which you asked about. Why cooperative? Because we wanted health action to be sustainable in the long term. And we cannot depend endlessly on grants and projects. So we've created our own social enterprise. It's a health enterprise. And as I mentioned, one of the major revenue earners are the pharmacies. And from the surplus generated, the profits generated from the pharmacies, then we went on to manufacture our own brand of Ayurvedic medicines and wellness products, which are cheaper, green medicine, less side effects, and so on. Another important work is linking women workers with the public health system. We all know about the lack of transparency, accountability, and frankly, corruption in the system as well that exists. So how can women access all the services and entitlements in a clean way? Of course, this is also linked to our Seva Shakti Kendra. But we also link with private providers, we link with government, we set up dialogue so that there's full transparency and an enabling environment is created. And similarly, public health services are monitored. I mean, we give the feedback both on public and private care to the providers. But we have to build capacity of local people, especially women, for this so that they know what is good quality, what is poor quality. Many times people think if you just pay a lot of money, that's good quality medicine. So that kind of information, and then also serving on the government's health committees in rural and urban areas under National Health Mission. And finally, we've been very active on the policy front. Particularly active, you'll be interested to know on trying to push our government towards universal health care. We're not there yet. We've made some strides, but a kind of bottom-up grassroots campaign to push our government further on the road to universal health care. And of course, diagnostics and tools in the hands of frontline workers. That putting technology in the hands of frontline workers will be critical in the slow march towards universal health care. And of course, as you can see in the slide, we have been promoting comprehensive primary health care, including occupational health and mental health, and with a women's health focus, which is often missing. Perhaps we can go to the next slide, unless you have a question.
I just wanted to bring whatever you just now said together for the audience and related to the topic. So wonderful, you mentioned that primary healthcare and also early diagnosis and screening, and some of this work in terms of awareness, which is, the most important thing before you even get into any kind of diagnostics. You need to know, as you said, not knowing is something which is more of a problematic situation.
Sure.
The Seva Shakti Kendras, which is exactly doing this. And you also mentioned a model which brings viability to the cooperative, So my question is like, how do we bring all this together for what we are talking about today, which is diagnostics? I'm very happy to hear you said that, the sister should be technology enabled, and with that vision, I'm pretty sure like point of care diagnostics can be, can see the light of the day here. So I just want you to throw a little bit of light on how the economics of the diagnostics at the last mile, based on the experience that you just shared in the Lok Swasthya Cooperative.
Sure. So I think that will tie in well with my last slides, actually, which in which I've said what needs to be done. So maybe we can put that up, and then also weave in your question. So I think the first thing that we find is that there is very little preventive focus in primary healthcare. Even today, it's more curative, and there is a curative need, there is no denying, but there is a strong need for early detection and screening. And I think, and at the grassroots level, at the last mile, at the doorstep, and I think that's where medical technology that can be put in the hands of frontline workers at the last mile becomes critical. Because early detection, screening, and I think, this can be planned, as I've said in my bullet point there, it can be planned in a decentralized manner, where those of us who are developing the medical technology sit together with local people and actually plan together. It's exciting, marrying everybody's talents, pooling everybody's talents, and that can be done. And they are the best to tell us what works for them. Because, one size doesn't fit all. Decentralized planning by local people, decentralized implementation, doorstep approach through frontline workers that I've written here, those are guiding principles. But in this large country of ours, it necessarily has to be a tailor-made approach.
This resonates very well with what our last speaker also said, Dr. Sriram from Tata Trust. He said exactly the same thing: training and capacity building at the local level, for nurses, staff, and ASHAs, similar way. So I'm very happy to hear your same experience. Yeah.
Yeah, absolutely. Because, for example, I'm thinking even in the state of Gujarat, the northern part of Gujarat and the western part, which is Kutch and more desertified, we'll have to think creatively. There's scattered hamlets, scattered populations. One has to think both in terms of tailor-made, plus also, whether the revenue model would work for such far-flung communities and scattered communities. Then in South Gujarat, we have forested areas and some very inaccessible areas where, also internet connectivity is a huge issue still, so on and so forth. So there are these practical issues which only local people can guide us, and we can, of course, come up with alternatives, but it's the local people who will always tell us what will work and will not work. And we've always been in favor, as you can see in the slide, of putting such technology, such as you are developing, such as we have tried out in the past, in the hands of women. In the past, we had tried out Swasthya Slates, which was a technology developed by the Public Health Foundation of India. And we found that women were really excited to use this. This is a technology that measured blood pressure and also sugar levels in the blood of patients. And this went a long way towards screening and then further referral for diabetes patients. But what we did also learn from the Swasthya experience are a couple of things. One is that all the technology, systems, the device themselves and the procedures should be developed right in the beginning in consultation with informal workers.
Okay.
Because oftentimes we develop things in the lab, which is fine. Nothing wrong with that. We all do that. But they may not suit the realities of different groups of people in our country. So at least early in the process, there should be a consultative process. That's what we found. Whether it's for developing insurance products, health products, medical diagnostic tools, and whatsoever. The other thing that's important is the backup support, training, and maintenance. And that's where, frankly, we ran into some problems with the SWAS slate. We needed backup support for maintenance. Also, our members can be trained in the maintenance. They're ready to learn, particularly younger members. Our members' kids love to use all kinds of devices and technology. I mean, everybody understands that technology is the way of the 21st century and beyond. And they're excited to use technology. Technology is empowering. It's cool. When they're in their communities and they're using a smartphone or some technology, they're respected as well. But that training, hand-holding, and backup support will always be there. And as I said, all along the chain, we can train women and young people to take care of it. And then I think, importance of the revenue model. And this is something, Vanna, you and I have been talking about quite a lot, because we had thought of some technology earlier on, you'll recall. And then we found that the Gujarat government was planning to do the same thing at no cost. And so that becomes an issue then as well, because if we are developing a revenue model, putting it in the hands of workers, and where they would, and they're happy to charge. And by the way, our experience was that local people were ready to pay as well. They didn't have to go to a lab. They didn't have to go and stand in a long line in a hospital, public or private. So if you bring it to their doorstep, they're ready to pay for that service. But then the backup support has to be there. They have to know what's going on, full transparency, and so on and so forth. But as I said, if we're developing a revenue model, we can't ever be in competition with our government. If our government is going to offer the same thing for free, then obviously no one is going to take our services. So I think this brings me to the last point of policy dialogue, and something we have been saying to our government as long as I can remember, whichever government is the government of the day, that in a country that's as large and huge and diverse as ours, the only way to go to reach healthcare and diagnostics and diagnostic tools is to put them in the hands of frontline workers, to necessarily have a decentralized approach, planning, implementation, and monitoring. Otherwise, we have seen that many of these diagnostic tools and medical equipment gather dust in sub-centers and primary centers dotting our country. I think what we would like to see is to work together to make a change, to make sure that this cutting-edge technology is in the hands of frontline workers. And by the way, we have full faith in them. They may not have finished high school, but they're smart as anything, and they can learn even faster than some of us how to use. But there has to be that hand-holding and capacity building all along, and for some time to come. I think I'll stop here and be very happy to take questions.
Yes, so I request the audience, if there are any questions, please put it in the Q&A session. We have some questions here already, and I'll begin with that. So thank you for the detailed insights on how this can work. One question that I have is, in order to make the economics viable at the last mile, do you think that we need to involve any other external organ? You mentioned the government, of course, and the last speaker again resonated your idea where he mentioned that, the approach that Tata Trust also states that it should always complement the government system of PHCs, like exactly same what you said, to make sense. But do you think that we need any external organizations or support? Because you said the last mile, the informal workers are very smart and very, very technology friendly and with hand holding, which I think everyone requires, not just the informal workers. Everyone would require, and the entire maintenance and everything, the back end support, it can be done. But in terms of making it economically viable, any external organizations, or do you think that the population dynamics in terms of the volumes that are there and the areas that we can access are enough to come up with a viable model?
So I think a couple of things. I think we do need external people. Certainly, organizations like ours don't have that wherewithal to sit and make a proper business plan. So that's one set of things. But our business plan would go for a toss if the government is going to come in the space and do it all for free. So therefore, from the beginning, I think it's important to be clear. Are they going to come in the space and in a way disrupt? I mean, we're all for them giving free things, but then why should we put our time and energy into doing something which then they're going to come and just give everything for free? I mean, our revenue model would be disrupted, obviously. But having said that, I think that having people who'd work with us to develop the business model, the revenue model, first of all, would be important. Second of all, as I mentioned, I think it's important to sit with the workers themselves, the frontline health workers, like say the ASHAs or the Seva health workers, and work out what's doable, what's not doable, what kind of costs roughly would people be willing to, pay. Affordability, paying capacity, all these things. You and I might have some rough idea of things, but it's important to test out, because otherwise our entire business plan would be based on wrong assumptions and premises. So I think we need both of those, and perhaps workshops. We've always found workshops where people making business plans, people who have the technology and the frontline workers sit around the table and hammer it out together always is the most fruitful. Because then we make mistakes and there are gaps, and then we have to go back and rectify. And that takes more time, effort, and money.
Right. Okay. So speaking of the government, I just want to touch base a little bit about what do you think about the Ayushman Bharat scheme and its impact on this preventive healthcare? Can it, reverse some of the situation of the last mile not being able to access, top quality care? Because they do have we have been working closely with them, and they do have a focus on getting innovations out there, like diagnostics innovation, the same way as we talked about preventive, early diagnosis, screening. So any thoughts on this particular scheme of the government?
Sure. I think the Ayushman Bharat, to my knowledge and understanding, has two important pillars. One is the Pradhan Mantri Jan Arogya Yojana, which is for secondary and tertiary care, which I think you're referring to. And the other pillar are the health and wellness centers, which will be providing primary health care at sub-center level and primary health care level, and also in urban areas. I think the concern is how to marry these two pillars. How are these two pillars going to work together? That's not immediately clear. Actually, in the ideal situation as a public health worker, what should be done is that people should first go to a well-functioning sub-center or primary health center in the rural areas and counterpart in urban areas. Should be screened there, and that at that level is where your diagnostic tools and equipment will come in handy right in the beginning for screening and early detection, so that we don't wait till they get really sick and have to be hospitalized. So the screening is undertaken early there, but then we must have full complement of services plus human resources plus medicines and so on, and diagnostics, including the ones that we are developing. And then, like a kind of gatekeeping from sub-center and primary health center, then only they should be going on to the secondary and tertiary care. So it's not clear right now whether that is happening. My information, and from what I've seen on the ground, is that that's not happening. Those who have the PMJ card, they get sick, they go straight to secondary or tertiary care. And finally, this is all going to be, frankly, unaffordable. I mean, right now it's coming out of taxpayers' money and the government monies. But unless we have strong prevention, screening, early detection, diagnosis, and here's where our equipment would be crucial, at the grassroots, at the last mile stage, which is sub-center, and then next stage is primary health center, we will see too much hospitalization and we'll see healthcare costs going through the roof. Already the costs are escalating a lot. And that's also with many people who have the card, don't know how to use it. Many people who should have a card don't still have a card. And even then the costs are going up. And the concern is that all of this should not happen at the cost of preventive primary health care. Yeah. So that's where I think our diagnostic equipment in the hands of frontline workers could play a critical role for early detection and screening. So we prevent people from going to hospitals in the first place. Nobody enjoys going there anyway. They lose their daily wage for which there's no compensation, at least for informal workers. Informal workers can't go and use the ESIC hospitals. Now, if they have a PMJ card, they can. So I think these are the kind of connections that we need to understand more.
Okay, thank you so much. So we are almost towards the end of our webinar. I have one last question. Since this is a MedTech Connect initiative, and you also brought out the point about how there should be a consultative approach. So I would like for you to, for 2 minutes, talk about what the role a platform like MedTech Connect can play in, what we talked about, like really empowering the last mile health workers with technology and, awareness and capacity. A few words from you on that.
So, as I've said before in our one-to-one discussions with you, Vandana, Seva would be very keen to explore partnerships with you folks to see how we can test out how the model works at the last mile. When we put this technology in the hands of women with the proper backup support, maintenance, capacity building, and so on, and perhaps even tweaking of what we have, our model, based on consultations with them. But I feel that quite early on, as I keep on saying, we need to talk to the frontline workers themselves who will be using the technology and get their inputs as well. So I see actually a very important role for this kind of technology, especially when it's put in the hands of the barefoot health workers, the ASHA workers, and the frontline workers. And by the way, there are now, I think, 10 lakh, that's 1 million ASHA workers. There are 14 lakh, 1.4 million Anganwadi workers. These people are a huge resource. Yes, Seva has a health cooperative, but we are not government. Ours is necessarily a limited kind of geographical distribution, although we're growing. But, there are lakhs and lakhs and millions of frontline workers, women, young people who are really ready to adapt this and adopt this kind of technology, use it. And it's empowering. Technology can be empowering, gives them greater respect in their community, especially for women. I think, speaking from our organization's perspective, we would be very keen to explore further with you and your team and others who are working together on the new technologies.
Thank you so much for that. So there you have it, folks, right from the horse's mouth, how Seva is very keen to work with all the innovators that we have here in our network. So with that, I think we are at the end of our time. So I want to thank you so much, Miraiben, for making this time and speaking to our small family of MedTech Connect partners here. And for the folks who have joined us, thank you so much for making the time to come and listen to us. We continue our conversation with Dr. Shuchin Bajaj, founder and director of Cygnus Hospitals, in the next episode, which is on 19th of December. He'll be talking about role of private providers for taking diagnostics to the last mile. Same time, same place. So stay tuned to more from MedTech Connect Diagnostics 4.0. Our blogs episode details are all on the slide here. Please subscribe to our webinars, and our website is medtechconnect.in. And we are also present on Twitter at medtechconnect_. And so this is, again, thank you for joining, and thank you, Miraiben, for making the time. I know you're very busy and just leaving tomorrow and going outside the country. So thank you again. So
Most welcome.
from me, Dr. Vandana Sada, and my co-host Pawan and Manish, signing off, and thank you all for listening. See you next time.
Bye.
Bye.